Hello, my name is Erin McShane, and today I am presenting my quality improvement project, Improving Tracheostomy Delivery for Trauma and Surgical Critical Care Patients. The Eastern Association for the Surgery of Trauma recommends tracheostomy within 7 days of intubation for patients with traumatic brain injury or requiring prolonged mechanical ventilation. These recommendations are based on evidence from 24 studies. Tracheostomy within these guidelines has been associated with a number of improvements in patient care, including decreased hospital length of stay and ventilator days, improved patient comfort, decreased ventilator-associated pneumonia, and improved ICU cost of stay. As part of ongoing quality improvement work, we sought to better understand tracheostomy practices at Stanford and determine strategies to decrease our average time to tracheostomy. Our methods are summarized on the poster, but I will provide some extra detail in this discussion. Stanford is an American College of Surgeons verified Level 1 trauma center, and our study took place within a mixed medical surgical ICU. Our study population included patients who received tracheostomy by the acute care surgery or surgical ICU teams between January 2017 and July 2020. We excluded patients who received emergent tracheostomy or tracheostomy for SARS-CoV-2 infection. We conducted interviews with nurses, residents, and fellows to better understand factors contributing to tracheostomy delay at our institution. We implemented an educational rollout, which informed these parties on the benefits and potential risks of early tracheostomy. Additionally, we published guidelines for early tracheostomy targeting patients with traumatic brain injury in the Trauma Guide app. We analyzed our interventions respectively through chart review. Our primary outcome variable was time to tracheostomy, but we also recorded hospital length of stay and ventilator-associated pneumonia. We used bleeding complications as a balancing measure to protect against unintended adverse consequences. Now I will explain our results, providing discussion and limitations along the way. We observed a decreased median time to tracheostomy for all patients. It changed from 14 to 18 days. And this is measured after intubation. We also saw an associated decreased hospital length of stay. We performed subset analysis for trauma patients and for patients with traumatic brain injury. We saw similar results for the subset of patients which were trauma patients, but we did not see a significant difference for patients with traumatic brain injury. We anticipate that we would have seen similar results if we had had a larger population, but we only had 31 total patients in the traumatic brain injury subset. However, we did see a significant difference in the timing of family meetings for patients with traumatic brain injury who received early tracheostomy. The runtime chart on this poster is for all patients, and you can see that the frequency of late tracheostomy decreased with each intervention. We did see a trend of increased late tracheostomies in the most recent quarters. We suspect this could be explained by changes in ventilator practices and resource allocation during the pandemic. However, it's also important to consider whether we are properly maintaining our interventions to preserve their effect. The table provides supporting data for many of the conclusions I have already explained. We did see some increase in our balancing measure, bleeding complication, but rates were still very low. Ultimately, we are not concerned that early tracheostomy is causal for more bleeding complications, but this should continue to be monitored as we strive towards earlier tracheostomy. In conclusion, we found that educational rollout and institutional guidelines are effective ways of improving this aspect of patient care. We also saw that early family meetings are a key driver for early tracheostomy. There is more opportunity to decrease time to tracheostomy through standardization of family meetings and through extending our early tracheostomy guidelines to the broader trauma population rather than specifically targeting patients with traumatic brain injury. As prediction models for tracheostomy need improve, we should consider using these models to enhance physician ability to foresee the need for prolonged mechanical ventilation. Thank you for coming to my poster session.